All right, it's 10:01. I will call the meeting to order and we'll turn it over to Princess Hugh. Well,
Thank you. Okay, so I'll start with yourself, Chad Richards,
present.
Nick Saunders, Nick Saunders, Nick Saunders, Sue Carlton,
Present.
Kevin Eccles, Kevin Eccles, Kevin Eccles, Shirley Keaveney,
Present.
Andrea Matrosovs, Andrea Matrosovs, Andrea Matrosovs, Kenneth Craig,
Present.
Don Murray, Don Murray, Don Murray, Jay Kirkland,
Present.
Beverly Wilkins,
Present.
Helen Claire Tinglin.
Good morning, everyone.
So good, and yeah, give our best to Nick. He's feeling under the weather today, so I'm gonna do my best as chair today. See how things go. Moving on to item 3.0, we've got some new board members to welcome, so we would just turn it over to them to say a few words. So Jay, sorry.
I don't usually have a lot to say. I told Dr. Air, I came here with an open mind. I didn't read up on anything, and I don't get on social media, so I don't pay attention to that, and I don't respond to that. So, but I'm the mayor of South Bruce Peninsula. Never been elected a mayor of South Bruce Peninsula. I was appointed, so been 6 terms and pre-exceed amalgamation from old Annabelle. So been involved with politics a long time, so joined and looking forward to this board and how it runs and what goes on.
Great. And Don is not quite here yet. Sometime during the when he arrives, we'll get Don to say a few words. And Shirley, yeah, great.
Good morning, Chad, and thank you very much. I'm Shirley Keaveney, Deputy Mayor, Municipality of Meaford. I'm in my 3rd term over there and have sat on a number of committees through County Council, but have never had the privilege of joining the Board of Health. So I'm very happy to be here and very interested in the work of this board. I had a wonderful first meeting with Dr. Aaron, so I feel that I've got as much knowledge now of what the board is all about. So I'm just really, really happy to be here and to be part of the great work that the board will undertake for the next couple of years anyway. So thank you.
Okay, welcome to you both. Very perfect. So yeah, welcome to you both. We're looking forward to working together and with the new appointments from Bruce County, Chris Peabody, when you want to be on the board. We just wanted to quick thanks. Thank Chris for all of his work as a board member and all vested in them for a valuable member for a while, and we appreciate his service. Moving on to item 4.0. Would ask at this time if there are any amendments to the agenda as proposed. Seeing none, I would entertain motion then to adopt the agenda. Looking for underwear in a second. Moved by Shirley, seconded by Kevin. All in favor? Right. Perfect. So we've adopted the agenda as presented. This time, I ask if any board members would like to declare any pecuniary interests. Being raised, just looking to declare. Moving on to 7.1. We're looking for an educational item in the past. So this time we'll turn it over to you, Dr. Aaron, to provide some context for the
Thank you, Mr. Chairman. The educational notice related to our policies, and one of them is election of chair and vice chair and other directors. If I can ask Elisa to share this, or if you want, I can share it from Elisa.
Okay, 1 second, and we should be able to share.
So one of our policies require the position of board chair and vice chair to be selected on rotation between Gray and Bruce. And last meeting, the board had its election, and Mr. Saunders was selected as chair or voted as the chair. And we needed to amend this policy more or less to reflect an open way to elect a chair other than Gray and Bruce, since Nick Saunders is from Nanewash First Nations. And we can amend with this one in different ways, whether we can add Saugeen and Nanewash or just remove the clause altogether, or other ways that the board might see appropriate.
When I read that, my thought was to have it be, positions be selected based on membership on the board. And that would leave it open to everyone who's on the board.
I am agreeable. I believe that there should be a variety, but as our practice, we made a mistake in contravening the policy the first time. So when policies are generally amended, it is through a referral to the executive committee. And, I don't care that it's amended, but you don't change policy because you made a mistake in applying it. You amend policy because there's a reason to do it. So I would like to recommend we refer this to the executive committee. There might have been a why. Like, why was that? Was it because it was the funding partners? Was it a provincial mandate? Was it a historical thing? I don't know the reason behind that. So I would prefer some consideration by the executive committee, supported by our medical officer of health, and do it in a fashion that we would normally amend policy, rather than just having the debate here. And I don't want to fix the first mistake by making a second one. I want it considered for the reasons that we're trying to do it, rather than just fixing something. So if that's an appropriate path forward, I would recommend that.
Dr. Aaron.
Yeah, thank you, through you, Mr. Chair. Thank you for considering the policy as the first step in managing the policy for review of policies. It says that we will do it every 2 years, we review all policies. However, the board has the authority to change any policy at any time. The executive committee is a subcommittee to the board. It's not the leading force that dictates what the board needs. So when the board made the decision to elect Mr. Saunders, it definitely within the power of the board to change something within the policy itself. And the fact that it's a bylaw of the board. It's not a law. If it was a law, yes, we cannot really intervene it, but it's a bylaw. So that election, I would say, it stands perfectly. To correct it, we can correct it at the board here. But there's no need to go to the executive committee unless it is part of that delegation that happens every 2 years.
Kevin, and that health there has a comment on mine. Sorry, I missed your earlier health there, but Kevin.
So in reading that, it says rotation between Bruce County and Gray County. You're saying that this is the first, but it doesn't say anything about an elected official or Gray County or Bruce County Council. It just says rotate between Bruce and Gray. And if Nick being voted in wouldn't be the first time that this policy, if you're reading it as a council member, because Al Barfoot was not an elected official when he sat in that chair a couple of years ago. He was from Bruce County. And that's exactly the same, yes, Nawash and Saugeen are kind of, but both of them are in Bruce County. So reading through it, I would say we're still compliant with the way the bylaw is written. Nick Saunders comes from Bruce County. comes from Nawash, which is in Bruce County. So I don't even know why we need to change it.
Claire?
Thank you, Mr. Chair. I did raise this issue last meeting prior to the vote. I did just flag it and say perhaps we might need to look at it. Having just heard my colleague, Mr. Eccles, it depends how, as a board, we look at this. If we're looking just technically from a geographic point of view, then absolutely the policy could stay as it is if we are delineating the entire region that we serve as either Bruce or Grey. Just from a larger lens, especially the lens of equity, Mr. Chair, which again I did raise last meeting, the First Nations do consider themselves separate too and are governed separately. And that's why we might want to look at the language. I'm not a fan of us just inserting and Nawash because we may end up with additional members from different First Nations that I would not want to hamstring the board to not be able to then make it an inclusive merit-based election. So from my view, two things. The election last month was valid, it was legitimate. I did raise this issue prior to, and the board voted in Mr. Saunders. So the election stands, in my view. With regard to this, it does need to be fixed, or we need to just let it go. The easiest way, in my view, would be simply to remove that line so that there is no requirement to alternate, and that we're just looking at whomever each time an election occurs is deemed best suited for these positions by the board. Thank you, Mr. Chair.
Thanks so much, Claire.
Yeah, I echo Helen Claire's answer completely, and I will just emphasize on the part of equity reconciliation. Our board had many positions supporting reconciliation with the Indigenous communities, and from that lens, I would say not having the First Nation as a separate entity because they see themselves as self-governed entity, including them in Grey and Bruce from that lens might not be suitable, although technically I can see that, geographically it's within, but out of the position of our board to support reconciliation and consideration, either we can say remove it completely or put Ms. Carlton mentioned to just membership on the board as required. Either or probably would stand there.
Talk about the issue as well.
Certainly, since the policy is being updated, there has been a notion of the length of term of the chair, and it was identified as a step for improvement. During historically, just for the benefit of people around the table who are new, historically the chair term was 1 year, and around the start of the pandemic, for a couple of reasons, the chair continued for 2 years, and that happened again 2 years. And during that time, it was very clear that the person as a chair would have more time to see projects through. There's more stability, more certainty. After that period and emergency, we went back to the 1 year. And again, it was identified in a couple of views as a way to improve the functions of the board. The former chair, Carlton, identified that if it is increased, it could be definitely a positive step for the board, for the functions of the board, for the functions of the health units. So I looked at different resources, and one of them is the length of term for chair with certain references. I asked actually ChatGPT to compose the summary of these resources, and to my delight, it was a polished gem. In 20 seconds, I reviewed it. Obviously, it relates to the references. It increases the continuity and stability of the board. the effectiveness in implementing strategic objectives, building relationship and trust, and leadership development, succession planning would allow for that, if the chair is there for 2 years or 3 years or 4, whatever the board decides, the vice chair would have that years of experience as well, and everybody would be more comfortable in their role for that length of time. And the final one is alignment with the best practice in governance, and information for the board to consider and decide what the right term is, including, keeping it as is 1 year.
Discussion on including that within the scope of the potential amendments to the policy and then changing term limits of the chair and vice chair to 2 years.
Having just come off 1 year, you're finding new things all the way through that year that the chair is supposed to be doing for the Board of Health. It would be nice to have that second year to kind of get things done to, if I would have had a second year, I would be really focusing on what does the chair need to be doing so that there's actually a list of duties for the chair, which doesn't really exist at this point. It's known by others that, oh yeah, we do this every year, but there's not really a list that could be followed. And I think that second year, I don't know as I'd go to a third, but definitely the second would be beneficial to let the chair really get to know what they're supposed to be doing. I found it difficult getting into.
Helen Claire?
Thank you, Mr. Chair. And through you, I completely agree with my colleague, Ms. Carlton. I think 2 years is the optimum. I think extending the position of chair, the term, and vice chair for 2 years is the optimum to allow success for each of those positions. We do have, of course, municipal elections all the time, and as a board, we have had a significant number of new members, and no matter how good the intentions are, there is a body of knowledge that needs to be acquired to serve this board. And it is different knowledge because, of course, we are not subordinate to municipalities, and we are above the county level as well. We are a discrete, separate agency. So there is an awful lot to learn. I believe that a 2-year term for both of these positions allows us to optimize and rely upon the knowledge that is gleaned in those 2 years by the people that we have voted in. And it allows the rest of us around the table to observe and to learn as their journey goes along as well, so that when the new election comes after 2 years, the people that are volunteering have that body of knowledge necessary to serve the board at its highest and best level. Thank you, Mr. Chair.
Thanks, Helen Claire. Any other discussion? Jared?
Just trying to wrap my head around the whole discussion.
Yeah.
So we've moved on from the first discussion. How do we solve things? So when we first started this meeting, we were talking about Grey and Bruce counties and our nations. Do we solve that at a later date, or are we doing that in a system? We're already on to now a term thing, which is fine. I'm just trying to figure out how do we resolve things with a resolution on the table or a notice of motion and then vote on it and then move on to the next thing, or do we encapsulate everything in a whole page and then try to vote on everything at once? So just trying to get my head around things.
For sure. So we want to have some discussion about the policy itself and potential changes to the policy, both when it comes to the policy about the selection of chair and vice chair, and then also have a discussion about term limits. And at the end, we're hoping to entertain a motion that would amend the policy based on the direction of the board or refer to executive committee as can propose. So I would entertain the board some.
Oh, near the end. Okay. So I'm okay with a 2-year term and I'm fine with that. So if it coincides with the elections. So if election is in 2026, first 2 years would be, we haven't decided whether it's Grey and Bruce or not. Second 2 years would be, and then of course, a new chair would be elected at the beginning of another election. But my understanding is chair could be an appointee person or an elected person.
Correct.
Okay, so it's not always just elected people that become the chair. Okay,
It has been just, well, pretty much elected people other than Al Barford. We haven't reflected that difference here. I think if we go to membership on the board, makes you eligible for either of those positions, it simplifies it. I would also question, does it have to transition from Grey County to Bruce County and back and forth all the time? Or should it just be the person most qualified and able to be the chair at that time? And I think we might find that'll even itself out anyway. I just wonder if that transitioning back and forth. Because if we're gonna say that, then we need to go from Bruce County to Grey County to our Indigenous community.
but. Sorry, through the chair. So, and once again, excuse me, my ignorance for just
Go ahead.
first meeting. Real easy solution on the Gray Bruce or thing is, and I heard Kevin saying, you know, Bruce County and our nations are within Bruce County. If we just add Bruce County and the nations and Gray County. So when it is a 2-year term for Bruce County, like there must be a reason in the past, and I can see where Councillor Craig's coming from. There was a reason this was set up for Bruce County for a term and Gray County for a term. I don't know what it is. Should we be looking into that to make sure there's a reason that we're not creating another problem? I'm not sure, but a real quick solution. And it seems that adding the nations and reconciliation to this scenario has created this wording problem. Well, if you want to just add Bruce County and the nations, it means that the 2-year term of the chair would be from Bruce County or the nations. The next 2-year term would be Gray County. That would be a solution to be almost leave the wording the way it is, other than adding the nations to Bruce County. So.
I wanted to jump in on that.
Thank you, Mr. Chair. So the history of it is a practice, more or less the legislative framework we operate under as health units and boards of health is called the Health Promotion Protection Act, and it's part of the orientation later today. And it's very clear that there will be 4 members from Gray, 3 members from Bruce, and up to half the board from provincial nominees. So this policy is really not consistent with that. It's just more of a practice that happened. And if it is removed, most likely would be the better outcome than adding the nations there. Seems to be reasonable to us, but being trained in the North, knowing how the Indigenous communities see themselves as a nation. So Trudeau as a prime minister would be the equivalent of the chief of that nation, and the nation would be consistent with Canada, not the county. So I would worry about that lens of Indigenous reconciliation to include the nations beside the counties. I know I'm splitting hair here, and it's practically geographically is not aligned, but out of respect to the community, probably we should list the nations with the counties. And removing the whole clause, or like Ms. Carlton mentioned, the membership on the board is sufficient as a clause. I think that would be more appropriate than including the nations on the list. And one final point, the term of provincial nominees is usually 3 years. If it's the longest, sometimes they start by 1 year, then they renew it for 3 years. And so to align the 2 years with the election might not be practical. Having 2 years would just be 2 years. And if somebody's term ended, the board would manage similar to any other council that something happened and the person couldn't finish.
Shirley and Ken.
Thank you, Mr. Chair. I just wanted to add my support for both Dr. Ararat and Member Carlton's position of simplifying this to just reflect membership from the board, because I'm fearful that, you know, as much as we would try to be careful with our language, there's always a risk associated with adding a reference to First Nations. So again, I prefer to keep that simplified. And my question in relation to term for the chair is, are we firm on 2 years, or could that chair be reelected for another 2 years if he or she chose to have their name stand?
I don't see any policy that would limit a re-election of that chair, but I think an election would have to take place 2 years following.
Through your Mr. Chair, that's correct. If there was something that limits, and historically it happened where somebody was for 1 year, then
Kevin can help.
Which is why, once again, I will reiterate my desire that it comes through the executive committee. We started with a simple question, and now we have several considerations. I believe supporting Dr. Ayer's comments and in a roundabout way yours too, Shirley. I believe that we should have the conversation with our Indigenous community and say, how do you want to be identified as part of this way, or this way? I think it would be incorrect of us just to assume that, you know, the province is going to appoint a particular member from an Indigenous community. We don't know who the appointees are going to be. There might never be somebody from the Indigenous community on our board for a period of time. So I would like that conversation with our Indigenous communities to see, how do you want acknowledgement of your participation on our board here? You know, whether it's 1 or 2 or 3, it's going to take some conversation. You know, how does that work? How do we do that best? And we can sit and we can debate it more, not come to it. But we have very capable members experienced members on the executive committee. And I think our time will be better spent to direct them to do the research, make the recommendation. And, you know, your subcommittee is there for its wisdom and experience. And
Why does he keep looking at me? I've never even sat on that, you know, I haven't had a meeting of this executive. I don't think.
anyway, so that you know, we can decide that here and now. I would move that we refer this to the executive committee for consideration to return a report.
So Ken put a motion on the floor. Is there a seconder for Ken's motion that the discussion of the policy be referred to the executive committee?
I will second that.
Andrew seconds. Any discussion on the motion?
yeah, there are 2 parts to the comment. The first one is the opinion of the Indigenous community. The chair himself, as Indigenous, is supportive of increasing the term, and whatever the board decides, 2 years, 3 years, 4 years, is comfortable with anything. The part of referring to the executive committee is more or less subcommittee to the board. Again, it's a tool that the board uses if there is a significant amount of discussion or multiple options to sort through. We do have 2 straightforward changes either to be made or not. I would really recommend against going to the executive committee. It's another meeting, it's another few weeks, and we come back to there are many other things that we can look at in that executive committee other than sorting out 2 things that seem to be straightforward. But that's my advice to the board. Obviously, I'm the advisor, not the head chair.
Helen Claire on the motion.
Thank you, Mr. Chair. May I move an amendment to the motion on the floor?
Certainly, yeah.
So I move to amend the motion to read: the position of board chair and board vice chair shall be selected from the board.
I don't know if that's a friendly amendment to the motion, so we probably consider that outside of the scope of Ken's motion.
I'm sorry, I can't hear you.
No.
Was that disallowed? Is that the gist?
Yeah, I think it's outside of the scope
Okay.
of Ken's.
All right. May I speak then to the motion, Mr. Chair?
Yeah, absolutely.
Thank you. Just to reiterate what I stated a month ago prior to the election, the historic alternation between Bruce and Grey County, I suggest was when only Bruce and Grey County was recognized. We've come such a long way as a society, and specifically around this board table, in our recognition
Under order,
of
Chair, this isn't about a movement to the referral. This is about what the report is that the executive committee may or may not return. So I would ask your ruling on whether this is related to the motion or a debate that happens within the board discussion. It's just a referral to the executive committee, that's all.
But how can I finish up your thought there briefly, and we'll put the motion to the question.
Sure. Thank you so much, Mr. Chair. The global issue that I'm trying to raise and that I tried to raise a month ago is about diversity of voices and about having the most competent person and people in the executive positions of this chair. We hamstring ourselves when we put token amounts, and it also requires that everyone around the table self-identify. Just because someone doesn't come in as a specifically Indigenous member appointed by the board, or rather the province, does not mean that any number of other people around this table might not also be Indigenous. Thank you, Mr. Chair.
There, I think with that, we'll put the question to the board. Don, go ahead.
Could I ask one question, being new here? What is the consistency of other health units? Like we got here in Birch, we've got all Middlesex, London. What is the consistency? Because all them communities, most of the communities have First Nations groups in them. So
I think
I
that
would like to know whether it was elected officials or if it's appointed by the board, whoever sits at the table.
for sure. I think it's a discussion the executive committee would have, should the discussion be referred to them as per Ken's motion. So maybe if there's any other discussion on the motion itself to refer to executive committee, sure.
Thank you, Mr. Chair. I think in my mind, again, being new, we've heard from Dr. Era twice now that this decision can be made at the board level and perhaps really should be made at the board level. And I'm curious to know if anyone has had this conversation with Chair Saunders, being Indigenous. Does he have any input into any change in the language that should be represented here? I'm thinking that he would be the best person to provide insight into what we should be doing with this.
Mr. Bowden is an executive committee, so he would have that. Thank you.
Thank you. Through you, Chair. And the reason I seconded the motion is because it was my understanding that this would allow the discussion. It would also allow the executive committee to reach out to our First Nations and be able to bring back to us, to the table, to the full board table, what those considerations are, which would include the input from our chair as well. So do I understand that correctly?
Correct.
Okay, thank you.
Chair.
Yeah, and just to define, and I go around here, I'm talking with Ken's motion is to define what Dr. Ayer had said, the things that we are looking for from the executive committee to keep them in a scope of the answer that we want back to this board. So if it is the two questions, the wording, and whether it's a 2-year thing, period, figure it out, bring a recommendation back to the board. Because just from what I'm hearing, I don't know if we're gonna be able to come up with a decision. I consider this fairly an easy thing to do, and it's already apparent to me that it's getting outside that scope. So I would rather have the executive committee, and I'm not knowing who sits on it or what goes on at that executive committee, bring a recommendation back to the board so we can put it on the table and have a discussion, a more scope discussion with answers.
That would certainly be the process. The executive committee would consider what's been put to the board this morning and then come back with a recommendation to put out that. And maybe we'll go. Kevin has the last comment on this.
Put forward an amendment that the executive committee bring back recommendations for the next board meeting.
Yes.
Guys, accept that as a friendly amendment.
Absolutely.
But so moved by Pam, seconded by Andrea, that the board refer this matter to the executive committee and bring forth a resolution for the next board meeting. All in favor of the motion? It's carried. Excellent. Thanks everyone for the input. So that's actually the next item is 8.0. That's the minutes from the last meeting. Is there any amendments or flags for the minutes that in the last meeting? Yeah.
Mr. Chair, the minor amendment to rename there was an error instead of Sue Carlton, but Sue Harrison, and this would be corrected.
That happens all the time.
At least you're not Shirley Keegan today.
No, I'm not.
So Sue, not a Shirley.
Proper Sue noted,
Maybe we should change that.
Yeah, I,
oh,
yeah.
another amendment. Mrs. Keating, Mr.
They're kind of close in the keyboard.
So, my apologies. All good.
Very close to the two amendments with the discussion. Board, all in favor, I'll ask for a motion to approve the minutes. So moved by Sue, seconded by Kevin. All in favor? Perfect. So moving on to item 9.0, correspondence and media releases. So,
Thank you, Mr. Chair. So the list of correspondence for this week includes a number of things. One of them is a letter from the board chair of Peterborough Public Health to the federal minister of Families, Children and Social Development, and the letter encourages the federal government to explore how income policies may essentially be designed to address household food security, be strengthened, and with other recommendation. And the recommendation there for this item is to receive the second correspondence to the letter from the Mental Officer of Health for Middlesex, as he was directed by the Board of Health for Middlesex London Health Unit to forward an internal report. Results. The recommendation there is to receive. And the last correspondence is a letter from Bruce County announcing the new membership on the Board of Health as listed, and people who are welcome to the this. The recommendation is also to receive. Chair, opening discussions as always.
Is there any discussion from the board members on any of those items? None, so entertain a motion that the correspondence be received for information. Moved by Andrea, seconded by Don, and all in favor. Before we move on to media releases, one thing that we did at the top, Don was introduction of our new members of the board. Don came in during a healthy discussion of board policy, so we can get a chance to introduce yourself. So Don, you can introduce yourself to the board. Welcome.
Don Murray, Mayor of Mary Kinloss, Deputy William Bruce County. Just an ordinary guy that lives out in the countryside. I love the farm. Raising a couple grandkids right now, and 4 other kids. So all is good in Mary Kinloss. I think we had over 30 feet of snow in the last week. And we're getting dumped on right now. When I got here, I said the sun's shining beautiful, and my wife sent me a picture, and it's just crazy. They're southern Bruce County, so I blame it all here in county for all the hot air blowing the dark wind. Oh, yeah.
So you're truly not just an ordinary guy then.
Thanks, Don. And moving on to section or item 2, we've got media releases, and I see Danny has joined us. Thank you.
Thank you, Mr. Chair, and through you, there are 2 media releases on this month's agenda. The first, issued on December 23rd, announced the appointment of Mr. Nicholas Saunders to a 1-year term as the chair of the Grey Bruce Board of Health, and this release includes comments from both Chair Saunders and Dr. Era. The second release issued on December 24th on the request of the Board of Health related to the challenges that many people face during the holiday season if they're dealing with grief, loss, or isolation. The release included tips from CMHA for people navigating a grief journey, as well as resources and other places people can turn to if they are experiencing these types of challenges. And that concludes the media release report.
Thanks. Any questions for any of the team about any of the media releases? Seeing none, and I put a motion with the media releases be received by the board top for information. And Shirley, seconder, Jay, all in favor? Perfect. And we have 10.0, the sort of updates and the key.
Thank you, Mr. Chair. So the first item is the opiate situation, and just a verbal update about a study from the Western University Research Project. And they're looking at whole of society resilience, and one of their subjects to study is the SOS program, the social outreach program in and Bruce Health Unit, and as people around the table know, it's a collaborative effort with all the partners and around the table. The paramedics at Play have been playing a significant role. The primary care, the pharmacies, all of it. It's worth noting that the project was designed by Dr. Zayer, who used to be the physician consultant in Health Unit, was for that for a number of years, and this project is getting more recognition and more recognition. It won the award in Ontario for the specific award related to the American market as well. So just for information there. The second item, Sir Chair, if I can share my screen, it's an interactive tool. I received a couple of questions from board members and sometimes partners about different aspects of the opiate or other causes of death or mortality or visits to the ER or the hospital. So I thought sharing this tool, and it's designed by Public Health Ontario, I put it on the screen, and for anybody can go and look, for example, on all-cause mortality, and it's an interactive tool, very straightforward. The data is classified by health units. So if we choose Grey Bruce there and we click on it, the mortality, all-cause mortality will light up, and it's this column over here in a list of comparing to other health units, and we are on the lower side, and that's one indicator of health. And the other one is the graph under a trend over time from 2012 to 21. Some of the data is up to date to 2023, 2024. And they keep updating it based on the indicator. All-cause mortality has many points of input. Like if there is a death, it could be related to opiate or it could be criminal activity. So it takes time to be sorted out, and the data might be a bit lagging. But in general, we can see there was a steady and for the past few years increase. And if you click on the comparison, you can compare it to all Ontario, but that might not be a fair comparison. Sparsely populated urban-rural mix, the red one at the very bottom, and as soon as you click on it, it gives you the graph, the trend over time, and where we sit in Grey Bruce as lower mortality than the rest of rural urban mix in Ontario. And it's worth noting that for the past 3 years, there is increase throughout the province in this sector versus there is a bit of a decrease in Grey Bruce. So again, this is one indicator, and as policymakers, as partners, as whomever listening to our meeting can go to this website. It's Public Health Ontario. It's a very robust organization. It's arm's length from the government. I happened to work there for 6 months, and I can attest to that. Their recommendations usually are non-partisan, and sometimes it's followed by the government, sometimes it's not. Nevertheless, they stand by the science. And you look at any other cause of mortality, whether it's opiate or alcohol or other things, and a person can actually reach certain solid conclusion based on this. And if people are interested in a subject or not, they can see how significant it is, how we fare as a health unit comparing to other health units in general. Just want to share this with the board for information, and this might answer the question for a number of people who asked about sources of data for mortality or for health in groups. I'll stop there, Mr. Chair, open to questions as well.
Through you, Chair. Thank you, Dr. Eric. Interesting chart to use. Could you give me a sense of any reasons why Grey Bruce, other than the excellent work of our public health department, of course, Grey Bruce is known for a lot of reasons that might cause mortality. That we are unique to Grey Bruce, like our rates of alcohol consumption, etc. But it indicates on the chart that Grey Bruce is not just a little bit, but I would say significantly lower than the other comparator sparsely populated rural communities. Can you give just a broad overview? Is there a particular reason that separation would be there, that difference, other than the Grey Bruce Health Unit? That was my caveat.
Certainly,
Is it economics, or is it closeness to Lake Huron, or is there a broad reason?
Through you, Mr. Chair, I wish you can take credit for it as a health unit. We are, as a budget, we are 2% of the healthcare system. But we are very mighty because we try to prevent things from happening before people fall off the wagon. And I wouldn't be able to connect this lower rate, and your right is significantly, I made the graph a bit bigger. You can see right over each column there is a margin of error line. I don't know if people can see it. I can try to make it a bit bigger. It's not there at all. I want to make it bigger. At the top of each column, there is a T, a little T. This is the margin of error. And if these T lines overlap, means there's no difference. And you can see the T for Grey Bruce does not overlap with the very top of the list health units over here, or the average line. So we're way under the line. And then similar to the same margin of error in elections, they will say that two candidates are different, but the indicators are overlapping. Here, there is significance, so you're correct with the word significant. The reasons for health are multifactorial. The best indicators of it are the social determinant of health. It's a list of 10 to 13 indicators, and guaranteed, if you Google any public health organization, and you Google social determinants of health, you're going to find income at the top of the list. So income dictates the health of people. Employment, level of education, gender, access to healthcare system is way down the list, 8 or 9. And there's this list, so it's very difficult to connect what causes what. In general, there are multi-factors for it. To be specific about one part of your question, what makes Grey Bruce different? For example, deaths of injury, we have a bit higher level of it, and maybe that's related to the industries available, the farming. It's a very demanding profession, and there are certain injuries that happen on the farm that are more significant than somebody who's living in Toronto. That's one example of an indicator where you can zoom in. But in general, why we're doing better than the rest of the province, if I had that ability to answer it on the spot like this, or even after a study of 2 years, I probably should go to Nobel, pick up my Nobel Prize. And Mr. Chair.
Just to add to that question, and we had this discussion earlier, Dr. Ayer, the way we live, and you look at Bruce Nuclear, And the cost of living in Grey Bruce compared to some of the wages that half of us are making helps with your health. And that's what you were explaining to me earlier, that we're a healthier community if we're a richer community. So, you know, we have people earning the same dollars and cents as a person in Toronto, where their cost of living is double what a cost of living is here. So the dollars and cents available for us to make sure we can buy certain things for diabetes or cancer, and we can do that. Maybe in certain areas you can't do that when you don't have the income. So I don't know if that reflects to this. Yeah, the income helps healthcare.
Yeah,
Through you, Mr. Chair, that's exactly what it is. I think this is the one indicator income, and it can affect health in many, many ways. Better diet, less stress, you name it, better environment, better houses, better air. But there are the other indicators and how they interact with each other. There is so much complexity in it, and I don't think it's one of these things that straightforward answer. This is better than this because of that.
Kevin?
Geez, Jay, that's terrible, because if income and the income of a politician, I'm gonna die really soon.
I'm with you. That's why we drink.
No, he says you make more money, live longer, so obviously in a politician, I'm gonna die soon. And of course, that was accepted very well. A lot of you think that's a great idea. It's not.
Sure.
Thank you, Mr. Chair. I just wanted to ask of Dr. Arrow, I mean, we just read earlier here in correspondence about food insecurity, 1 in 5, correct me if I'm wrong, I believe is the statistic for our area. So I'm just wondering in relation to that, if we have a greater amount of resources in relation to the need, even in terms of healthcare, and Kevin's going to throw his pen at me, but you know, do we have a higher level of access to healthcare in relation to larger centers where people may not have doctors, but they can still get to an emerge? And is there just any impact of either of those things on mortality?
Through you, Mr. Chair, definitely both are part of the social determinant of health. Food insecurity is an issue that affects many communities in Grey Bruce. It's worth noting the report that in the correspondence comes from London. It's very similar to our area, but we have our own data collected, and there's no surprise to see the report coming from London since it's internal, but I don't know what the reasons why they send it. The second one, access to healthcare, is definitely one of the reasons for health. It's way down the list. It's not one of the major ones. And it's unfortunate that because of that geography and rural areas, and usually if you connect the system, the healthcare system, urban to rural, usually the money flows in one direction. 20, 30 years ago, maybe the hospital in Chelsea and the hospital in London were well funded for their size and population. Then suddenly there was a connection among hospitals through LIN or other layers of bureaucracy, and the money would flow usually to the bigger urban centers. And fast forward 30 years, Chesley Hospital is prime time versus London, way bigger hospital for its size.
Discussion of those items. Reading 10.2.
To the strengthening public health bill, that's.
Yeah. Yeah, so maybe we'll move on to item 10.2, strengthening the public health.
Thank you. And this is a standing item similar to the one before. And the last two updates to the board were about the review of the public health standards for Ontario, and it was verbal, but now it's written. We received a letter saying that the review will be completed and we will receive the new standards, which is the regulations that we operate under the Health Promotion Protection Act. And they will receive them in August 2025. They will be effective next year. When the initiative started, the plan was for these new standards to be effective January 2025. Nevertheless, the consultation was thorough, and to the credit of the ministry, actually, they allowed feedback from different levels, from the health unit, from the MWH, even the directors, two of our senior managers contributed the review, and part of the consultation was to allow time for the transition. We can turn our services overnight on a dime, but that's not gonna reflect the need of the public and Grey and Bruce. So a slower transition would have been would be more appropriate. And again, to my delight, the ministry allowed that transition. And that's for information, Mr. Chair.
Any discussion from the board on that item? Seeing none, that's all the items for the medical officer health update. So with that, we're moving in second here, that the medical officer health update is received by the board for information. The mover for that motion, moved by Ken, seconded by Stu. All in favor? It's carried. Perfect. On to item number 11, services replacement.
For you, Mr. Chair, the November 2024 financial update. So as of November 30th, we had a cumulative surplus of $189,000, primarily from our senior intensive program, which was the result of some carryover one-time funding that we had from the beginning of 2024. Our mandatory base programs had a small surplus of $18,000. I confirmed with the ministry earlier this week that funding approvals for the dental capital projects are still being finalized. So we're hoping to receive something soon regarding the Walkerton Dental Clinic that we completed in 2024. In the event the amount approved for the Walkerton Clinic isn't sufficient for what it costs, we can use that senior central surplus or a mandatory program surplus to cover any shortfall. But the amount we requested, if we receive that, would cover the full cost of the renovation. For our expenses, our salaries and benefits continue to be under budget. This is due to the vacancy in the physician consultant role, which we are actively working to fill. And we also had some gapping in program positions for various leads, and we've been backfilling and replacing those. For our operating expenses, our November spending exceeded the budget by $31,000 as programs continued with their year-end spending. But year to date, we're still under budget in this area. And some notable purchases in November were some replacement tablets and annual license renewals in IT and a new sterilizer in the dental. And that concludes the November financial update.
So just for clarity, what do we do with surpluses at the year end? Do they stay in reserves for that particular department, or do we put it in a general reserve? Do we reduce next year's budget if it's, like, how do we treat that?
So through you, Mr. Chair, it gets returned to the province. And we are in a cost share between the counties, so Grey and Bruce County contribute their 25% and the province contributes their 75%. So anything out of our mandatory base, that's kind of like our big overall global pot of funding is our mandatory programs. So whatever the surplus is there, it gets proportionately sent back to Grey, Bruce County and the province. And then the seniors dental is 100% funded by the province. So any surplus there will go back to the province.
So we aren't allowed to handle reserves.
Yes, we have no mechanism to
Okay.
retain any surplus internally.
Okay, so then my second question is then on the salaries and benefits. Without the physician consultant role, how has that handcuffed the board? Like, is this a position that is needed? Has a person just, that role been empty for a month? Has it been empty for a year? Is it something that is needed for the future? Is it something that could be a different role? You said you're having difficulty replacing or putting somebody into that role. Is just, I guess the main question is it needed? Is it, or could it be dealt with in a different manner or a different position?
So, Mr. Chair, good set of questions, definitely. The physician consultant role is a position that transferred to be an associate medical officer of health. And there are a number of health units, almost, I don't know if it's half the health unit or not, are trying to recruit more associates. It's very difficult to, and some health units have been trying for 5 years. The physician consultant that was with us, she resigned and she moved to a medical officer of health position in a different jurisdiction in a different province. And we started recruiting immediately. We were, I would say, well served by a number of applicants, and we landed one. We're in the final stages of, we sent the offer, but and when that's signed, we will bring it back to the board. We have been updating the board about this. The position itself is supportive to the MOH's office. And so can we operate without one? Yes, we have been operating for a year. We haven't dropped the ball. It is a key position for redundancy. In case the MOH is not here, we usually have to go to another health unit to cover for the MOH function. And there is a mutual assistance agreement with the 7 health units in the Southwest. So that is manageable. So all the aspects of the position are mitigated. However, for the succession planning, for redundancy, if there is emergency, there you need more capacity. And our health unit would qualify for that position. And we have been one of the very lucky or well-served health units to actually have a physician consultant almost continuously, except for this few months, I'd say.
So then when you talk about succession planning, and do we look within our organization to move people into positions such as this, or is this a position that can only be held from a certain professional that we, I always look, and I use building inspectors as a something in our municipality. Every municipality is fighting for building inspectors. But when we can promote within and have succession planning within, we seem to be able to retain those positions a lot easier when it's people that are in your community or belong to your community. So I didn't know, is this a position that could be dealt with and somebody trained within our organization to move into this position? Or are we always looking to the outside to bring in? Because I find that very difficult to do because you're in a competition with other medical health boards.
So through Mr. Chair, both are correct. So we don't currently have anybody internally who can be become a physician consultant. By definition, we have to have the qualification of a physician and the specialty. And this specialty is very rare, actually. You know, there are 34 health units or 30 health units at this point. In Ontario, there are 30 MOHs, and many health units are short of associates or physician consultant. So you cannot just choose any staff. It has to be qualified physician. And the process is robust in a way that you would need to, they need to meet certain qualifications. Then they need to be appointed by the board to become an associate down the road after they become physician consultant. And the third step is the ministry has to vet all the qualifications and the appointment, and they need to approve it. So it's multiple layers. The staff that usually a health unit would have would not be able to become a physician consultant. When I said both can happen is the fact we were trying to be proactive, and we have been proactive. The health unit since 2021 become a learning site for Northern Ontario School of Medicine, an approved learning site. So we have a number of students, medical students, and residents who are physicians in training to be specialists that come through the health unit. And actually, the candidate who is becoming the physician consultant came here as a medical student a long time ago, before we became an approved site. They had rotation with myself, then and with Dr. Lynn, I believe, around that time. Then they came back as a resident 2 years ago, and now more or less they're finishing their specialty and they applied among other people. So we're not upgrading or promoting our staff to become a physician consultant, but there is a plan in place, and it's working very well to attract medical students and physicians to the area to hopefully down the road become physicians in the area. So,
Okay, thanks.
Yes, thank you. Through you, Mr. Chair. Just to add to that, it's my fervent wish that this board be so well respected in the work that we do, and so reflective of the region in which we live, that very small talent pool of possible candidates that could succeed and become medical officers of health. I want them to want to come and work in our area and for us. Of course, the medical officer of health is the only employee of the board, but of course also it's not at all like a building instructor in so much, or an inspector in so much as there are so many requirements. And at the end of the day, it is the province that determines whether or not we get the staff. So I want us around this table to be the best we can be, to have other people say, wow, that unit, that region, I want to go work there. And that's my fervent hope. Thank you, Mr. Chair.
Thanks, Ellen. That's our New Year's resolution for sure. Dr.
Thanks, Mr. Chair. Just want to add that on average, we have 2 trainees that would go through the health unit every year, and that's a significant number. You know, we look at, again, there is no way to look at something and measure it without comparing it. You look at Windsor Health Unit, double our size population-wise, and they have been trying to recruit a physician consultant since the pandemic started. And I don't believe, I'm sure they only have 1 RMH, not associate. So again, there is enough work and quality of training in this institution to attract people continuously, which is something, you know, for our board to be proud of. The leadership here caused this to happen. It's always top down in these matters.
Any other discussion? Public affairs about it? Hearing none, looking for the seconders of the financial report we received by Health Board. Should move by Kevin, seconded by Claire. All in favor? It's carried. Perfect. And on to item 12, other business. That would be Alpha and Winter's proposal. So
Thank you, Mr. Chair, and for people who are new around the table, Alpha is an association of public health agencies that includes health units and many other agencies working in public health in Ontario, and it's a vocal sound and voice in Ontario for supporting public health initiatives. There are 3 symposiums a year. And there will definitely be good discussions and excellent speakers and subjects related to public health and the up-to-date summit in Ontario. And usually, historically, before the pandemic, we used to attend at least 2 or 3 individuals from each board. And after the pandemic became virtual, so there is also the opportunity for in-person in the spring as well. Just for information and friendly reminder, if people would like to attend, please help with arrange for that registration.
So just like the process for that, would just be reached to please. I think of a better Valentine's Day.
His wife's birthday is one down.
Is yours done?
Perfect.
An easy way to remember it.
Yeah. Perfect. That takes us to the conclusion of the meeting. So thanks for being patient with me in the first meeting. Taking the chair role. Hopefully make us back for the next one. And with that, we'll for moving to secondary, but the board of health committee to be moved by Don, seconded by Andrea. Favorite.